Thanks, Neil. Exciting news about the candidate application of the test. I'm going to shift gears a little bit and focus a little bit on the perspective from the laboratory, but also am privileged to be here today to show you some of the emerging data that's coming off of the bacterial trials. And as I understand, this will be the first public meeting for some of this data that's being shown on the bacterial side. Let's see here. There we go. So when we deal with sepsis, it's not surprising that we see a lot of management around sepsis that is largely empiric. And there's been a number of studies that have shown this over the years that continue to show this, that approximately 60% of effective initial empiric therapy is based on the empiric response. At our institution, we actually have a number for this. It's much higher at our institution. It's about 85%. The emergency department is the wheel that spins the admission from our hospital, and virtually everybody that's admitted is on an empiric-based therapy that when they meet clinical markers for sepsis. Unfortunately, we know that a large percentage of these patients are actually treated ineffectively. And we have a number of infections that we're believe now are too late in recognizing. And this has led to a lot of the surviving sepsis campaigns based out of data that's come out of Anand Kumar in Winnipeg and David Gajewski and Neil's stomping ground in Pittsburgh and so forth. So there really is a need to identify these. The mortality associated with these organisms is not trivial. As was alluded to, data from the 1970s clearly showed that for invasive fungal infections, including Candida, we still provide this diagnosis for some patients upon postmortem analysis, and that continues to be true today. So there's a tremendous insight into trying to get the diagnostic needle moved to recognize these patients both clinically, but also what diagnostic support can help in these patients. So I need to take a step back here and remind people that in order to give this talk, I really put the screws to T2 and asked if we could show some of the emerging data. And fortunately, they allowed us to do this. This is one of the first times in my career that a company has stepped up and allowed data to be shown prior to submission at an international scientific forum. So I give the company a tremendous amount of credence for allowing us to review this and talk about it in the scientific and clinical forum. This is some of the data that's coming off of the trial. There are no claims granted to this data yet, and much of the data that I'm going to show you is still under adjudication. But what we can see here is that we have roughly 260, 250 patients that we've enrolled into trials, looking at overall sensitivity claims of over 95%. And specificity claims of over 98 in terms of recognizing these key pathogens. These are the escape bugs that you'll hear of before, T2Bacteria, E. coli, Enterococcus cleb, Pseudomonas, and Staph aureus. These are the organisms that we worry about drug resistance in, but also that make up a fair amount of the sepsis, the etiology of sepsis that we're seeing. This slide here is very important to talk about. As was shown in Neil's data set, it's important to recognize that although we've been dealing with diagnostic support for sepsis for quite some time, the truth is that we lack a clinically validated, verified diagnostic criteria for the diagnosis of sepsis. As many of you in the audience know, SEERS is now dead, and the working definition of sepsis now, as part of the international group that published in JAMA a year ago, has now defined sepsis as life-threatening organ failure due to host response systems. So we continue to see a number of cases where we recognize sepsis as a clinical entity in the patient for which diagnostic support needs to step up. I see a few colleagues in the audience that I recognize on the clinical lab side, and this is one of the challenges, I think, one of the most frustrating components from the laboratory side. When we see these patients with high lactates, with high white counts, that people come to us and say, do we have anything growing yet? And we need to recognize this in the context of this data. So I'm going to walk you through it here and identify roughly 102 positive infections that were pulled out of the trial that's represented in this data set here. Paired T2 blood cultures alongside identified 35 of 39. But importantly, just as Neil showed, there were 63 cases for which a T2 positive signal that a blood culture was negative in. These working definitions are defining the totality of sepsis in regard to organ dysfunction. And for many of these cases, in fact, for all of these cases, they met certain clinical bars associated with sepsis, including the use of additional high titer positive samples from other organs representative in a septic patient. So these cases are still under adjudication, but they're taken to be a further insight into the recognition of sepsis from a new diagnostic modality. And this is going to be the integration of these new technologies alongside what laboratories have been able to offer for years. Blood cultures are not going away, but this is the new integration of new tools and new skills that allow us to identify sepsis in ways that we've been unable to do it previously. So very exciting data. There are a number of examples that I thought would be worth sharing that are coming off of the trials when we talk about it back to the patient. We tend to view this data as aggregate data, but the truth of the matter is we view patients individually. So I thought it'd be worthwhile to share some of the data coming off. This is the folks from Rome who have published a number of cases on this in ECMID last year as well as this upcoming year. And this was a case where they saw a 68-year-old man with myasthenitis gravis who was admitted to the ICU for respiratory failure. Patient had a high fever, chills, tachycardic, difficulty rapid breathing, suspected focus of infection was his abdomen, and he was started on therapy with Mero and Vanco. It took 41 hours for the conventional blood culture processes to process, compared to 4 hours for the T2 bacterial. In this case, this patient had a number of organisms involved in the septic picture, but some of those organisms, particularly the use of E. coli and Kleb pneumo, were identified early on within a 4-hour window using the T2 system. This is another case, a 77-year-old patient with pancreatic carcinoma was admitted to the ED. Therapy was initiated with piptazo. The conventional modality looked at about 23 hours of speciation and identification. You can see the chain of events that led to the laboratory diagnosis on this. Once again, the T2 system was able to identify partial septic picture in this patient within a 7-hour time frame. There we go. Here's a third case, again from the same hospital in Rome, a 33-year-old with polycystic liver disease, renal disease, sepsis, and a previous history of sepsis. These patients are particularly difficult when we get into the renal impairment of these patients, as everyone is aware. Take 5 days to result in a negative blood culture result. But the T2 was able to identify E. coli signals present in this patient within 5 hours of identification. And these are the types of stories and cases that we look forward to with increased recognition that our diagnostic tools can identify signals that we've been unable to recognize before. This is some data closer to home with Robert Wood Johnson and Mel Weinstein's group. Case 1 is an elderly male patient on hemodialysis with a recent history of VRE bacteremia that was diagnosed about 3 weeks prior, developed high femurs, became hypotensive, admitted directly through the ED. ID was involved prior to the initiation of the antibiotic, probably because of the acuteness of the clinical picture. Blood cultures are drawn as per normal process, as well as the T2Bacteria, which was positive for Kleb pneumoniae. Blood cultures were negative, including subterminal cultures after 5 days. And Tom Kearns presented this data last year, I believe, at IDSA as well. Case 2 is a patient with Enterococcus faecium. Positive blood culture sets on therapy, repeat blood cultures the next day were negative, but we continued to see detection as these tissues likely leach these signals back into the bloodstream. Case 3 is a set of blood cultures drawn in a febrile patient with suspected bloodstream infection. Consented over the weekend for the use of the T2. T2 bacterial was run the following day with positive Staph aureus. Blood cultures later provided that Staph aureus signal as well. So we're still learning, quite frankly, the integration of these tests, but these cases clearly give insight into where we're going to start to receive data off of the test, which begs the million-dollar question of who do we run these tests on? And I do think we need to be selective in terms of the patients that we look at. But clearly people that have risk factors, and Neil did a great job on the Candida side, which is a little bit more mature compared to where we're seeing some of the exposure on the bacterial side. But we can clearly see that we're dealing with a number of patients for which risk factors predispose them to bloodstream infections. It is important to acknowledge that the role of this test in septic events associated with community-acquired pneumonia is probably not there yet, in part because the test is still lacking some significant bacterial targets such as strep pneumo and so forth that would make it an application for community-acquired pneumonia. But clearly the organisms that are defined on the panel have a role for sepsis. So people are going to look at risk stratifications for this, of where we would use the test, in what settings, and data on this, quite frankly, still yet has to be defined at individual institutions. If a lot of your population, like Neil's, is a large transplant center, you're going to have different variables that factor into where you would like to employ the test relative to other sites. And there's a number of groups, including ours, that are working to help define some of the pathways, but also some of the financial analysis and clinical outcome data needed to support the use of the test. But we can recognize a key pathway that is emerging with the use of the test, where traditionally we would admit patients, we would have key decisions, we would look at source coverage, or we would look at source control, and we would look at appropriate coverage, and refine the optimal time to therapy, as well as the optimal therapy as well. We hope that with new and emerging technologies, we can continue to push the envelope of how we look at these traditional timelines to identify information that allows us to successfully treat patients. All three of us on the panel beforehand were talking, and I think I speak for everyone on the panel, that we're in agreement that what's right for the patient will ultimately turn out to be what's right for the hospital and cost effective. So the idea is to try to push this envelope, to try to provide some support, certainly from the laboratory, for the initial empiric response that's needed for the detection of sepsis. So it's important to recognize, and I mentioned this earlier in trying to describe some of the data that was coming off of the bacterial side, where we're starting to see signals where blood cultures are negative. It's important to recognize that sepsis is a larger definition than we've ever understood before. And the working groups in sepsis have helped to define this very nicely. And we now look at it as the identification of acute organ dysfunction as a result of host regulation that we start to see associated with a septic event. And there are a number of places where we'll look for the initiation of sepsis. It's an important thing to recognize as we go forward. One of the questions that clearly is going to be asked by the microbiology group, as well as the clinical groups, is what is the coverage of the panel relative to what we see for sepsis? So I thought I'd show you this. This is some data we're continuing to work on. Fortunately, I work at the University of Minnesota, where we have a number of talented infectious disease fellows, a very strong infectious disease fellowship program, and we have 2 fellows that are going to dedicate their next 12 months to helping us understand further some of the impacts of not only diagnostics, but the role of sepsis as well. This is a snapshot from our institution that is still yet to be defined, but this is about a quarter of all the sepsis that has come in through the emergency department in 2007 and 2016. The panel will cover between 85 to 90% of the patients that we see that enroll through our emergency department with acute pictures of sepsis. What's not covered, we're still looking at some of those findings. I don't expect anybody to be able to read this, but this is just our etiology of what we're seeing at our institution. You can see the vast majority of these are coag-negative staph signals. We're still looking as to the clinical implications of actually seeing some of those coag-negative staph signals. There's some invasive streptococcal disease. There's some invasive pneumococcal disease as well included in there as well. So we believe at our institution that we're actually going to look at this as a test and as a modality that will help our emergency department physicians with the sepsis pathway responses. The sepsis pathway is not going away. It's not going to turn into what happened in the 90s with the pneumonia pathway. CMS, the last number that I looked at, had somewhere between $6 to $7 million invested in the sepsis pathways. They're not going away, and the laboratories need to be able to step up to really help providers with the pathways in the emergency department. And we really feel a test like this that can identify the vast majority of our septic events through the emergency department within a relatively short time frame is going to set the hospital up for better patient outcomes going forward. This is data that we continue to look at and continues to evolve, so stay tuned for this story, but we're excited to be part of the groups that are looking at this. Finally, I want to remind everybody, what can we expect from earlier diagnosis? And what have we learned from early rapid identification? We continue to move the needle forward in the laboratory. It's a great time to be involved in diagnostics. The laboratory folks in the room will recognize this paper at first glance. This is one of the most sentinel papers in the field of microbiology, and I'm not underestimating that assumption. This was the group at the University of Michigan, led by Dwayne Newton's lab, and a group of very talented PharmDs that looked at the implications of what happened when hospitals brought in MALDI-TOF technology, time-of-flight mass spec, for identification in 2013. You can see on the left-hand column here, we see a nice table with variables affecting all the things we want to look at, particularly 30-day, all-cause mortality. As was alluded to by Neil, this is a very, very important parameter. The ability for us to be able to look at pre and post interventions with the use of novel diagnostics that improve outcomes with 30-day, all-day mortality cause is a very, very important parameter. It basically proves that we're providing successful outcome for our hospitals and our patients that walk through the door with septic events. We look at length of hospital stay, we look at the time to effective therapy, all of these traditional now contemporary modalities that we're asked to look at from the laboratory. But you can see here on the figure on the right that what they have is their traditional time scale and the ability for the group in University of Michigan to show that they were able to intervene by moving the needle closer and closer to where the patient first presented to the system. In the red arrow is approximately the 20 hours that we still lack, because no matter how good our MALDI-TOF technology is, the results of it are still dependent on the function of the growth properties of the organism as a turnaround time of the properties from the laboratory. And we have roughly a 20-hour window there where we feel that new technologies like T2 can come in to really make an increased event in terms of recognition and results from the laboratory. So we've learned from studies like this about what we can expect to learn from an earlier diagnosis. This study was not particularly focused on sepsis, although a large percentage of these patients were septic patients, but you can clearly see that we have hope for optimism here, where new technologies will come in to continue to move that needle closer and closer to where the patient presents to get the information that allows us to be able to give the right information at the right time to the right people that can make those decisions. And that really is the hall of stewardship. It's the hallmark of appropriate patient care. So with that, I want to thank T2 for allowing me to show some of their early data. And as Neil suggested, we'll hold questions and I'll turn it over to my colleague who will talk a little bit about the stewardship approach.